All right. Hi, everybody. Good afternoon. My name is Peyton, and I'm the outreach coordinator here at NAMI Greater Cleveland. I just wanted to go over a few housekeeping rules for you. So, like I mentioned, this webinar is going to be recorded and it'll be uploaded to our NAMI Greater Cleveland YouTube page. So, please remain muted throughout the presentation so that we can avoid any background noise, but feel free to utilize the chat if you have questions. I'll be monitoring the chat throughout, but we will also have like 5 to 10 minutes for questions before wrapping up around like 12:45 uh, or 12:50. So if you are new here, I just want to give a quick overview. NAMI stands for the National Alliance on Mental Illness, and here at Greater Cleveland, our mission is dedicated to empowering those living with mental illness, as well as their family members, to achieve a better quality of life. And we do that by providing education, support, information, referral, and advocacy. We do provide support groups and education courses for people who are living with mental illness, as well as their family members and loved ones, and community education programs on special topics like this one. We also have a helpline that is staffed from 9 a.m. to 9 p.m. Monday through Thursday and 9 a.m. to 5 p.m. on Fridays, where our trained staff and volunteers are able to provide assistance with locating resources related to mental health and any other community resources that the caller may be looking for. I'll share the helpline number and link to our website in the chat. And I just want to give a quick introduction for our presenter today. We have Dr. Michael here, and he is a University of Michigan
Can I
trained
hear?
how do you say that?
Physiatrist.
Physiatrist, an interventional pain management specialist, double board certified with over 15 years of clinical experience. His career began with a broad focus on complex musculoskeletal and pain conditions, but in 2024, he shifted his practice primarily to focus on trauma-informed mental health care, and now he is the owner and medical director of Reset Medical and Wellness Center in Strongsville, Ohio. Thank you so much for being here, Michael, and let's get to it.
Thank you so much, Peyton. I really sincerely appreciate being here and having the opportunity to chat with everyone. And certainly it can be slightly informal too if there are questions that pop up in that chat, Peyton. If you want to interrupt me at any point, feel free, or we can, like you said, do questions at the end as well. So I'm going to get right into it. I'm sharing my screen. And what we're talking about today is an alternative but really innovative approach to treating trauma. And it's targeting trauma at the root cause of the injury. And we're going to talk a little bit about what that means, what trauma is, when it comes to how our nervous system receives that trauma and what options there are for restoring healthy function in the nervous system, and also some of my clinical research in the field. All right. So just briefly, disclosures. Obviously, like Peyton said, I am the owner and medical director of a medical center that provides this treatment, as well as some of the other treatments I'll mention. But I don't accept any money for speaking engagements or grand rounds. I'm not sponsored by anyone, and I don't have any direct connections or ties to pharmaceutical companies or device manufacturers or anything like that. As Peyton mentioned, I've been in practice for over 15 years, going on 20 years, and my background is started in Michigan, actually. So I did my training at University of Michigan. Don't hold that against me, all you Ohio folks. But I moved down here about 12 years ago now with my family there on the right. And we've been big fans of Cleveland ever since. I started my practice here doing a lot of addiction treatment as in 2012 it was sort of the peak of the opioid epidemic. There was a large need for that, and I have some specialized training in addiction treatment. So I began there and moved into more chronic pain management. But my frustration with those, the challenge, as many of you I'm sure know, is that there was a lot of relapse. There was a lot of band-aids that we felt like we were replacing and not really getting to root cause treatment, which the root of addiction and chronic pain often are physical and emotional trauma. And so in 2024, I partnered with a colleague in business and now business partner who we wanted to start this center to really focus on trauma care, to focus on root cause treatment, focusing on a specialized type of treatment that had been utilized for several years but hadn't really come into the spotlight as a standard of care yet, and that I had discovered along the way in doing other sympathetic mediated treatments. So our center is located in Strongsville, and we're an ambulatory surgery center, technically, although we kind of mask it as a wellness center. We have a welcoming environment, and what we focus on is really patient-centered care. We focus on all our treatments on anxiety and trauma-related disorders. Whether that's the physical aspects of anxiety, like doing Botox for migraine headaches, or trigger point treatment for myofascial tension, or really root cause treatment, such as ketamine therapy, which you may be familiar with, and cervical sympathetic blocks, which we've termed neurosympathetic reset, which you may not be familiar with, which is what I'm going to focus on today. We Again, we do ketamine treatment, and that often comes up in questions as far as how that relates to sympathetic treatment, and those are really two sides of the same coin. Ketamine therapy is used to help emotional dysregulation, to help depression, to help form more positive emotional connection with past memories. Um, Whereas sympathetic blockade is used typically to help nervous system dysregulation and excessive fight or flight response related to trauma. But again, both of those conditions, depression or anxiety, are often rooted in trauma response. And so they are sort of two sides of the same treatment, although we'll be focusing today on the neurosympathetic reset. So in general, and again, I think everyone here is well aware of this. This is a epidemic when we talk about mental illness and anxiety and depression being the most common. About 20% of the population struggles with mental illness, probably more. 12 million with PTSD, though because of the stigma or lack of understanding of really what trauma is, that number is probably much larger. And for better and for worse, there was a large increase in 2020 after COVID. I say for better because I think people started to acknowledge their mental health a little bit more after COVID. And I think that opened the door to various treatments, or at least approaching treatment in a more traditional way, as a mind and body approach, and not ignoring mental health. And so that created a big increase in need and diagnosis of anxiety disorders after COVID and trauma disorders. So, when it comes to trauma, what we really have to define, what we have to acknowledge, is the idea that that post-traumatic stress is in fact an injury. If we look at it that way, it does two things. One, it reduces the stigma that's often associated with it. And I see that uh, a lot, right? So, we think or we hear folks say that, oh, it's all, it's all just in my head. I can think through this. I can get over it. I can pull myself up. I can work through this. Um, or we hear, people say, oh, that couldn't be the case with me. My trauma wasn't severe enough. My situation isn't like others. I wasn't in the military. I wasn't assaulted. But when we look at it as an injury, I think people are more willing to acknowledge it. The other thing is, we can identify it. We can identify it structurally. And we're going to talk a little bit about that today too, because I think that's important. It helps in the diagnosis, which is um, a clinical diagnosis, of course, but sometimes with any clinical diagnosis, right, whether it's fibromyalgia or post-traumatic stress, uh, it's uh, it's sometimes vague to the patient, and that lack of understanding creates a disconnect between the patient and the provider. And so identifying this structurally, I think, is equally important for the treating the science behind it, but also reducing the stigma. Uh, so, so when we talk about trauma response, it really boils down to one simple human fact, and that is humans are really good at adapting to their environment. Whatever your environment is, right? Social setting, geography, climate, humans have evolved to identify and assess threats without even thinking about it, and then physiologically changing to match that, to best survive that situation. And generally, it's a good thing, right? So if you move to high altitude, you get used to lower oxygen levels. If you move to the desert, you get used to heat. If you're in, groups of big people, you get comfortable with that. It allows us to survive harsh conditions. But the problem is, of course, it works both ways. Our nervous system is very simple. And so if the environment is threatening or even perceived as threatening, well, you get acclimated to that also. And there's something called our allostatic load or tolerance for stress. And the more stress that we pile on, the more we approach that allostatic threshold. Meaning a little bit of stress is good, right? It kind of gets us motivated. We're goal setting. It's a good thing. But too much creates a breaking point, a point at which our nervous system starts to physiologically change because it assumes that stress is our new environment. I mean, we call it different things like burnout, but that's what it is. And that can be a single traumatizing event. It can be a series of lesser events, or it can be daily, regular stressors, work and finances and relationships. And that's, of course, what's critical to understand for patients is that it doesn't have to be, a war zone that you were in or a physical assault. It might be emotional neglect or relationship challenges, divorce and finances and bullying and all those things create this buildup in our nervous system. And what happens is once that builds up enough, then our nervous system begins to respond to everything as a potential threat, even when it's not. And it finds difficulty in establishing safety in our environment. And that leads to excessive sympathetic nerve signaling and essentially a cascade or feedback loop of sympathetic activity, of fight or flight responses. And the difficulty is, even if you remove yourself from those traumatizing and stressful conditions, those symptoms persist. because your brain doesn't instantly recognize safety anymore. It recognizes that everything is a threat. And it might be a social situation, a discussion. It might be just trying to get your mind to rest. It might be a sound, it might be a color, it might be a person, it might be someone who looks familiar, but your brain then cues in to these triggers, these things in our environment that then create this same fight or flight response as when it was under duress. And then the symptoms of hypervigilance and anxiety and emotional instability and irritability persist. And we can actually see those changes metabolically and physically on imaging. And so the image that's on the screen now is a study that was done a few years ago looking at glutamate activity, essentially metabolic activity in certain cells of the brain in two patients that were at rest. The patient on the left was diagnosed with post-traumatic stress, the patient on the right without. Both at rest, the patient on the left demonstrates significant activity in various cortical and subcortical areas that are that essentially represent ongoing sympathetic input or ongoing metabolic activity, despite essentially trying to rest, which is why you can't rest your brain when your body is in this fight or flight response. And that's what perpetuates these symptoms then. You don't get sleep, you continue to have irritability, and the cycle continues. And while I'm not a neurobiologist, I am going to do my best to explain a little bit of some of that neurobiology. Again, this stuff gets a little dense, and I want people to understand the ideas here and the concepts, but I also recognize I don't want to go too far into it and outside of my wheelhouse. But of course, one of the main things that we talk about when we talk about sympathetic overactivity is exaggerated activation in the amygdala, which is our emotion and fear processing center of the limbic system. Um, this is one of the, earliest things that was discovered and identified, and people often focus on that as the area of injury. Realistically, it involves a lot more than that. What we also see is a reduced activation, equally important, in the prefrontal cortex. So when we talk about top-down regulation, right, we talk about kind of identifying this trigger and then working through a process to respond to that trigger in a more healthy way. And that requires recognizing the trigger. It requires recognizing the coping strategy to engage afterwards. And it's this top-down regulation that is, in fact, reduced and inhibited in folks that have been through trauma. Their nervous system doesn't allow them to work through this cognitive process of understanding what the threat is, recognizing it, and changing. And that's often why it is a struggle with some patients, not all, but some patients that really have complex trauma, that have this dysfunction, this exaggerated activation in the fear processing center and a reduced activation in their prefrontal cortex and cognitive processing, to work through this in healthy ways. And getting to the root cause of that can be much more effective. Treatments like EMDR, of course, focus on reprocessing emotions and memories in a more healthy way. It does start to get to the root of this, but it can be challenging and it can take a long time, as you are well aware. Um, the other thing that we see is reduced size of the hippocampus. Now, whether that occurs after a trauma or whether people are more predisposed to develop post-traumatic stress because of a smaller hippocampus size is unknown. But what we do see is folks that are diagnosed with post-traumatic stress have reduction in their size of their hippocampus as compared to a standard. And that is linked to an inability to develop fear extinction training. And so essentially part of, say, exposure therapy is identifying something that might be triggering, that might be fearful, and recognizing that it is, in fact, should not be triggering, that it's associating it with safety, in other words. But that process requires a very well-developed hippocampus because you have to remember that this thing that you are afraid of or is triggering is, in fact, should not be triggering, should be safe, should be okay. And in folks that have this reduced volume, that is challenging, which again just creates more of this uh, exhaustive process of working through this that patients, unfortunately, often give up along the way on this process because it can take a long time um, to revert these changes that have occurred. Um, the bigger picture, though, is that we see that it's not really a specific one area. Again, historically, that's been talked about like, oh, it's in the amygdala, that's the problem. Oh, it's in the hippocampus, that's the problem. Oh, it's in this top-down regulation, that's the problem. It's really not. It is a network connectivity issue and it is stimulated and produced directly by a hyper-reactive sympathetic nervous system. And that's what creates this dysfunction in these networks. And let me move forward. This was a study that was done back in 2015 on the hippocampus, and they looked at different volumes of in patients with post-traumatic stress. And again, the one area that was consistent that had a reduced volume was the hippocampus. At the end of the presentation, and like Peyton said, she's going to send out the presentation. I have references throughout at the end that you can go back and look at too. The idea again is this imbalance though. You have this hyperactivity of the emotional processing system stimulated by sympathetic fight or flight responses, and you have this suppression of the cognitive prefrontal cortex, which is what's created this injury. And again, we can call it a dysfunction, we can call it an injury, we can call it a disorder. I like the term injury because it really identifies that there are structural issues, no different than walking on a broken ankle. I often tell my patients, sure, you can do that and you can work through it, but if we can address the underlying injury, it makes the rehabilitation process go much smoother. So how do we do that? How do we address the underlying injury? So that's where sympathetic treatment comes into play. There is a collection of nerves in the neck that is known by a few names. You'll hear the term stellate ganglion, you'll hear the term cervical sympathetic chain. For practical purposes, those are interchangeable terms, but it provides sympathetic output from the limbic system and the areas in the brain that we were just discussing to the body. So when this system is triggered because there's a bearer charging you, it's what sends that signal to your body to release adrenaline within about a tenth of a millisecond, to gradually increase production of cortisol, usually over minutes to hours to days. And again, the difficulty here is when this system is dysfunctional, not when it's responding to a single threat, but when it's constantly active. And so what again occurs is there's this back and forth, this feedback loop, outgoing signals that regulate physiologic functions, are increased, as well as incoming signals as those cortisol levels remain high, as adrenaline levels remain high, as this inability to create fear extinction processes remain, then it reinforces the trauma and reduces the inability to feel safe in this, again, self-reinforcing cycle of trigger, activation, and feedback. And so what we can actually do is under ultrasound, I can use a small amount of anesthetic, ropivacaine. It's a cousin of Novocaine, used commonly in various nerve blocks and regional nerve blocks and anesthesia, to pause essentially this feedback loop. Once we pause this feedback loop, even a temporary pause of just a few hours of this feedback loop, stops this constant metabolic cycle, this constant activity, and essentially allows the system to start to self-regulate. Equally importantly, what we know from past research from some of my predecessors and colleagues is that it starts to reduce a couple things in the brain that are really critical once we halt this feedback loop, and it happens instantaneously. One, it reduces norepinephrine. Norepinephrine is the fuel that pushes the sympathetic nervous system. So that immediately starts to go down. And the other thing is it reduces a neurochemical called nerve growth factor. Goes by a couple different names, but you'll hear BNDF or NGF. Um, and with that, it starts to reduce all that excessive sympathetic sprouting. Think of your brain like a tree, and there's all these excessive sprouts that the sympathetic nervous system has created to all these different areas that we looked at earlier in the brain, these areas of hyperactivity, and now they're constantly getting input. If we reduce growth factor along the sympathetic chain, then we reduce sympathetic sprouting in a process that is well known and often referred to as neuroplasticity. So the idea, although that term is often misused or overused, but the idea is that the brain can adapt and heal very quickly. It can change gears and reconnect different connections when needed and reduce connections that are no longer needed. It's the same idea behind any brain injury or healing from a stroke or a traumatic brain injury. The idea is that when stimulated or inhibited, the brain will form different connections to communicate in a more healthy way. And that's what this injection stimulates. It changes the way our sympathetic system is communicating with those parts of the brain that have been hyperactive and reduces that hyperactivity. But in more simple terms, it's like resetting your computer. It's hyperactive, it's stuck on, and we just turn it off and turn it back on, and it starts running smoothly again. Um, and the nice thing about this treatment is it's not a standalone treatment. It is meant to be an option for patients that are struggling with traditional treatments that can't move forward because they can't address those triggers, right? And you know the patients that I'm referring to, these are folks that maybe you bring up their three biggest triggers and they can't even identify or talk about the lowest one on that rung because it's so activating for them. And those are folks that will struggle to progress. And they may progress, but very slowly. And what this does is it really complements the psychotherapy aspect because it allows folks to feel safe again. It allows folks to address their trauma without being inadvertently activated or triggered. It essentially gives them the control back to manage their response to their environment without it being reflexic. And for that, it is very helpful and very effective. And the other thing, again, it does destigmatize treatment because when people identify their trauma as a physical injury, they're more likely to acknowledge it and they're more likely to do all types of treatments to address it. Again, traditional treatments like psychotherapy, maybe medication, but also sympathetic blockade. And one of the real beauties of this treatment is it is extremely fast acting. When we do this block, the benefits are noticed. We say within days to a couple weeks, but realistically, it's within seconds. So patients will still be on the table after this treatment and they'll have an emotional release or they'll laugh for the first time. They'll feel like a weight is lifted. When this system is so active that it's essentially going nonstop and you stop it, people feel that. Hitting the brakes hard on a system that's going 100 miles an hour, you notice it and you notice it immediately. So it's very rewarding, obviously, for me and my team. But it's really nice for the patient because it really allows them to transition and start to integrate treat other treatments right away. Um, all right. So, conditions that it treats. So, obviously, we've been talking about trauma and post-traumatic stress, but the reality is when you have there's a number of different conditions where there is sympathetic dysregulation, where there's autonomic dysfunction, we call it. And that includes post-traumatic stress, it includes anxiety disorders, insomnia, and depression, but it also includes things like long COVID, which is one of the things that I started treating back in 2020 um, when COVID was first here, using this treatment. And it's very effective because COVID, as well as a lot of chronic inflammatory and autoimmune conditions, work by stimulating the sympathetic system to over respond. I recently wrote a paper on a patient that had very nice recovery after a TBI from a lot of the sequelae he was experiencing from sensitivity to light and sound and lack of sleep, um, anxiety, headaches, all improved because those are often mediated by a chronic inflammatory response that occurs after head injury. Menopause symptoms, that's another one that we treat very commonly. Hot flashes is mediated through the hypothalamus and our temperature regulation system, which is purely under the control of our sympathetic nervous system. So, if a patient is interested, a lot of people ask, like, what does that look like for us? Are we just treating them and then saying goodbye? No. So my goal is to really identify how this best fits into a patient's journey when you talk about their trauma care. Again, my predecessors in the field have really done an amazing job looking at how this treatment is best done, the anatomy and physiology behind autonomic dysfunction, and um, how this treatment really works, but it hasn't yet been looked at how to best integrate it with other trauma treatments. And that's what we're very interested in. It's part of my research, And it's our goal here to make sure that the patients have this as part of a healing journey. And so when they come in to our office or before they even come into our office, my patient engagement team touches base with them, goes over their symptoms. We do assessments for their mental health objectively, PCL-5, PHQ-9, GAD-7, suicide scale, of course. We we do a medical consultation and a medical review and intake, make sure they are medically appropriate. It's a commonly asked if there's any contraindications to the procedure. Really, there are not. You have to hold blood thinners, so there are some patients that can't hold blood thinners. We don't do it on pregnant women, and we typically only treat patients 16 and over, although we do make some exceptions to that. Um, the treatment itself is done over 2 days. There are two sides to the sympathetic chain, although they both go to the same areas of the limbic system. We do the right side one day and then follow up a subsequent day to do the left side. The procedure itself takes about 20 minutes, and the patients are here for about 2 hours on each of those 2 days. And we follow the patients then afterwards out for the first 6 months monthly, and then out about 2 years reassessing how they're doing, how their benefit is maintaining, helping them to reintegrate those resources that maybe they're doing or maybe had given up on in the past, but might be more effective now. The procedure itself is done with ultrasound. If we have time, I have a short video of it. It really is a very quick procedure. But essentially, I place the medication along the sympathetic chain in the neck using ultrasound guidance. As I mentioned earlier, it's a very commonly done type of procedure. And similar procedures are done daily, preoperatively for things like numbing an arm before surgery. Same approach, same ultrasound. It's a very safe and well-established approach. There's some temporary symptoms right after the treatment. So as you can imagine, putting a bunch of numbing medicine in the neck and face, the area has some effects. There's some droopiness. We call it a Horner syndrome in the eye, warmth in the face, sometimes congestion. As I mentioned, there's often an immediate feeling to it. Sometimes it's exhaustion or emotional release. Those are common, and patients can't drive. And as I mentioned, we follow these patients out 2 years, providing resources along the way. We don't do therapy here. I encourage my patients to either continue with their current therapist, or if they don't have one, we have resources all around the country to provide suggestions for therapists. Um, Most of my patients actually don't come from Ohio. Most of my patients come from outside of Ohio. We'll talk about that, why that is, but I do have a lot of resources around the country, and I'm always looking for more. So if it's something that trauma is something that you very commonly treat, I'm very interested in speaking with you. And again, the idea here is that this treatment is not a standalone treatment. It's intended to be a catalyst for next steps, for deeper healing. It's intended to open that door so that patients can engage in therapies like CBT and DBT and IFS and EMDR, all those great trauma therapies that maybe hadn't been able to really break through, or the patient was resistant to previously. Briefly, I'm going to go over some of the research that was done. Again, these slides are all going to be available, so I don't want to spend too much time delving into every single study that's ever been done. But if you're particularly interested, I'm happy to provide all that research for you, and those references are at the end as well. So the procedure has been done for mental health for about 25 years. The procedure itself, just a stellate ganglion block, you may recognize that name if you've been in the pain field at all, because it's done for certain types of pain conditions. It was actually found sort of accidentally after Desert Storm. There was a lot of folks with upper extremity amputees, and one of the conditions that this block is used to treat, which is very rare, but is phantom limb pain. And these amputees, who of course had severe trauma, mentally and physically, um, were getting this block done for pain in the 90s. And they discovered, incidentally, that these folks were coming back reporting improvement in things like hypervigilance and nightmares. And so that's how it was really discovered, but it wasn't until a bit later that larger studies began to come out. This large case series in 2015, looking at, again, these names are interchangeable, but you'll hear SGB or stellate ganglion block, sympathetic block, dual sympathetic block. Um, so it began showing significant improvements, particularly with anxiety and post-traumatic stress that was being maintained well beyond 3 to 6 months. This study was a large randomized controlled trial published in JAMA in 2020 that showed clinically significant improvement in patients with post-traumatic stress with a drop of greater than 10 points in their PCL-5 scores immediately following this treatment as compared to a sham injection. Um, this study was just recently done by a friend of mine, Sean Mulvaney, on the East Coast, and he showed that not only was this treatment beneficial, but that the benefit was able to be maintained, which is really what's critical. So male, female, both showed that the response was almost immediate, baseline to 1 week out. Had a drop, an average drop of 28.5 points in their PCL-5 scores. And that benefit was maintained even out to 6 months in his study. And what was particularly interesting is he observed this in different trauma groups. Previously, much of the research had been done through the VA and military, and folks that were just only treating military. And so he was starting to see that, which makes sense, of course, all trauma groups, sexual assault, childhood trauma, military trauma, regardless of the trauma, there was the same response, which again makes sense because of the underlying injury that we're talking about. And then this is my study that we're currently actively recruiting for, IRB approved as of last month. And my interest is both in how these patients are maintaining that benefit beyond 6 months. So we're looking out 9 months, but also not just in their post-traumatic stress, but also in moral injury. That's really not been looked at, but I treat a lot of first responders. I do treat a lot of military, and we're interested very much in how how other aspects of trauma are affected, particularly moral injury. And then most important to me, looking at how to best integrate this into real world care. So how do patients do when they integrate this with psychotherapy, when they integrate it with mindfulness practices? What sort of is the best algorithm per se, and timing? Um, and so that's where this study hopefully will lend some light. And this is a very large study going on at the VA that's going back to those functional MRI images that we looked at, and they're looking at identifying patients early on to see if they can predict what patients would be most responsive to this treatment, how patients would benefit and sort of examine those predictors of treatment response. based on their functional MRI scans. And it's a multi-site study. Almost 400 veterans are being looked at. So we're probably looking at maybe 3 or 4 or 5 years before this is fully complete, but very excited for that research to come out in the next few years. Common questions I get, other than the ones I've mentioned along the way here, FDA approval. So the medication that we use, ropivacaine, is FDA approved for nerve blocks. So yes, but procedures are not FDA approved. There's no procedure that's FDA approved. The Food and Drug Administration doesn't approve procedures. They approve food and drugs and medical devices. So the drug that we use is approved for nerve blocks, but technically there's no procedure, epidural or appendectomy, that's technically FDA approved. What we look for is insurance acceptance, particularly by Medicare and Medicaid, and it's not yet part of the treatment regimen under insurance. So it's not covered by insurances, or at least most insurances. Um, we're hopeful to change that. That's part of, the research and the progress in any treatment. Um, but it's not yet covered by insurance. So we're very transparent with our costs. The cost for the treatment is $2,500. It covers the medical intake, the consultation, it covers the treatment itself, it covers the follow-up out to 2 years. We also advocate for first responders and military because I do treat a lot. So we give 20% discounts to them and their spouses. Again, not that trauma affects them more than anyone else, but I will say that they often are putting themselves back into traumatizing situations. And one of the common questions I get is, how long does this last and does it need to be done again? Well, again, we're studying that. We don't know the firm answer to that. It's a different for everyone. For some, it's a permanent treatment. For others, particularly those re-exposed to trauma back in active military war zones, they may need this again, and they do sometimes. Even those with complex trauma, like any trauma treatment, we're kind of using a stepwise approach to address their trauma, and we may get them improved, but not completely better. And so sometimes we'll see those patients come back and do this again. So we do recognize it's something that some people need to be repeated. Um, and so we try to make it as accessible as possible. We utilize advanced care credit, FSA, HSA. And the other thing that we do is we work with a number of foundations around the country. So back to what I was saying earlier about most of my patients coming outside of Ohio. So there are a number of foundations all around the country that provide or help to provide various treatments for post-traumatic stress in certain cohorts of individuals. Um, for better or worse, many of those foundations are for veterans and active military. Um, but there are foundations like Erase PTSD Now that is just for anyone that has post-traumatic stress that is in financial need of treatment but can't afford it, or in need of treatment but can't financially afford it. And so we work with these foundations very closely to provide grants to pay for the entire treatment and sometimes travel costs also of participants that are coming to have this treatment. In an average month, there's anywhere from 10 to 30 grants that we utilize from these foundations, treating individuals all around the country that are traveling here to have this treatment done. Because unfortunately, right now, there's only a handful of centers that are really using this approach properly for mental health. And we are one of the handful of centers that are doing it in a trauma-informed approach and utilizing this sort of integrative pathway to make sure the patients maintain this benefit. Okay, I said there would be maybe time. I might skip through a little bit of this, but this is a video showing the actual procedure. Of course, the patient signed a release.
So right now it's in color. I may have the color off when we do the injection, but either way, this is the carotid, this is the jugular, and right, if you hang on, a good view of it. A great view. Right here, this white circle is in fact the sympathetic chain of nerves or the stellate ganglion. And the needle will be coming in from the left side of the screen and coming right down to about here. And then this area will expand with fluid as I put the medicine in. So you'll kind of be able to see that in real time, but I won't be able to necessarily point to it while I'm doing it. All right. All right, I'm gonna numb the skin here, just the surface. There'll be a pinch and a sting. 1, 2, 3, pinch.
So there's two spots I'll be treating. I'm just going to show one and then I'm going to fast forward to the next slide because you'll get the idea. But it's a very quick treatment. I numb the surface with a lidocaine on the skin, which is a little pinch and a sting, and usually that's really all people feel for the whole procedure. Like the dentist office, you know, the little pinch with that, and then it's really just pressure afterwards.
All right, we're gonna get started here. So as we get started, you'll feel a little pinch on 3. 1, 2, 3, pinch. Good job. And if we're looking at the ultrasound monitor, we can see the needle coming in from the left side of the screen. You feel a little pump or pressure right there. It's right there, so. See the saline there, a swap, that's great. Great.
That's basically it. So I injected the medicine there on the left, right in here.
Part.
And that'll coat the nerve, which then essentially turns it off.
Okay with that, Hannah? You can talk. Okay, perfect.
All right, I'm going to fast forward here, just so in the interest of time. So this is a patient that was treated.
My name is Lovell. I am a recent patient at Reset Medical Center. I went through.
Oh, hang on.
Perfect. That first spot's all done.
Hang on.
All right, here comes that second spot. Pinch on 3.
Pause that one. Forward.
Okay. Just 2 days ago with my ganglion block, I got the right side done on Tuesday, left side done on Wednesday. So today would actually be my day 1. Kind of just adjusting to a new life. What I can say is that from the beginning of the entire process, I couldn't have felt more comfortable. My first initial conversation with Julie was a hard one for me. A lot of things that I didn't feel comfortable discussing, but she made everything a lot easier for me. And as things grew closer to the time of the procedure and I came into the office, I couldn't have asked for a better experience. When I walked in the door, I knew it was a place that actually truly cared about me as a patient and me as a person that was struggling with some things with my mental health. To give a little insight on me personally, I've been a career firefighter for over 15 years. I work at a relatively very busy department. Most of the time I spend on an ambulance running EMS in a very urban city that sees a lot of different things, a lot of different walks of life, a lot of different people, a lot of different cultures, a lot of different violence, a lot of different trauma. Sometimes I've been able to deal with that and sometimes I have not. When I came to the conclusion that I needed further assistance, Reset was someplace that I was unsure because it's not your typical place that gives a treatment that everyone is familiar with. The block is something that seems a little bit more invasive than what we're used to and what we're privy to as first responders. It's not something that they generally show us. But let me tell you, after being involved in it in the last 2 days and today being my day 1, it might be the best thing that's ever happened to me and possibly saved my life. What I can say is one day after the procedure, I woke up today and I didn't feel like I was at war with myself. And that's something that I couldn't say 3 days ago, 3 months ago, a year ago. Reset has given me hope. Reset has given me the ability, after just one day, to wake up and realize that life is beautiful. There is a lot of life out there, and there is a lot of life that I deserve to live, and I don't need to be at war with myself all the time. And if there's something that I can encourage all of you to believe in and understand, that it's not just a cliche saying, you're not alone out there. There are people who care. There is a fight to be fought, but it's a lot easier when you have people by your side with the same goal and the same mission. So I would just like to thank Reset for everything that they've done for me, for changing my life. And if I can encourage anybody that's on the fence out there, just take a visit, talk to somebody there, let them show you what they bring to the table, and allow them in so that you can truly feel that you're not alone.
All right. So that's it for me. I have a couple thank you slides here, but again, you can you reach me anytime. I'm always happy to chat. There's my email. You'll get these slides. We are having an open house next week, so I invite any and all of you. If you just want to tour the facility, if you want to chat with me and my team, I'm also giving a lecture where I'm going to discuss ketamine as well, which I didn't go over today, obviously. And thank you to NAMI. All right, I heard there was some stuff in the chat, so let me pull that up.